The current treatment of multiple myeloma, the first go-to approach is to get patients to a stem cell transplant. In time that may change, but right now, the best therapy is giving some therapy to reduce the disease burden and then getting a person to a stem cell transplant. However, many patients can't get to a stem cell transplant. There's a variety of reasons for that. They don't fit the inclusion criteria, first of all, for a clinical trial, that's involved in stem cell transplant. And anytime you don't fit that criteria for a clinical trial, that puts patients in a special bucket where these patients end up not going on other clinical trials, or when you look at their data, they don't do as well. They certainly don't do as well, even on clinical trial, as if they couldn't even get to a stem cell transplant. So this is a special group of patients, and it's not a small number of patients either in that regard. And what you're trying to do is increase the amount of time they actually can stay on therapy, because we know that that's beneficial. We know that proteasome inhibitors are very beneficial to these patients. And at the current time, in the non-transplant setting, there are no approved therapies for continuing a patient on for a long period of time, which is what we call maintenance therapy. You have induction therapy, which is a much harder regimen. It's usually, we'd like to see 2-3 drugs. 3 drugs is now the current standard. But then if you can maintain a patient on an agent like a proteasome inhibitor for a longer period of time, we know that this is beneficial. And this study, MM4, was actually designed for that in mind. This study actually is a double-blind, placebo-controlled, randomized clinical trial, and it randomizes patients after they have induction therapy of 6 to 12 cycles to either receive Ixazomib, trade name Ninlaro, at a standard dose, or placebo. And there's always debate about why a placebo in this case. It's because in many countries and many practices, standard of care after induction therapy is still to watch and wait. So, of course, placebo, and using that in a blind fashion, allows you to really evaluate a drug, because what we see is if people think they're getting that drug, there is definitely a placebo effect, but also physicians seeing different side effects may decide to modify a placebo just like they do a regular drug. And I think this is key, because this is one of the best trial designs you can get in this line. And so that's why it was designed this way. The end result, of course, is the fact that we see a significant difference in the progression-free survival between the Ixazomib arm, where patients were continued for 24 months on Ixazomib after induction therapy, versus placebo. And that difference is not only significant, but it's clinically meaningful as well. There is an 8-month difference, which translates to a 34% improvement actually in progression-free survival, which was the primary endpoint on that trial. And of course, progression-free survival is not only progression, but death as well in that equation. So, definitely very positive results.